Hi everyone, thanks for inviting me. When I was putting this talk together, I was trying to make what I'm presenting to you sort of applicable to your daily life. So I tried to include cases and patients that are a result of athletic type injuries, and things that you kind of will see, have seen, or will see in the future. And I hope at the end of this you come away with a few things that you learned. Please feel free to interrupt me at any time, ask any questions about any of the pictures or any of the cases that I present. I'm going to start by talking about soft tissue injuries like lacerations, and I'll focus on different areas of the face that we get called a lot about: the lip, the eyelid, ears, and the facial nerve and carotid area. And then I'll get into facial fractures. And these both talk separately are an hour talk in and of itself, so it's hard to truncate it to something within the time frame. So I sort of peeled away the most common fractures that you typically see in athletic injuries, which will be orbital fractures, nasal fractures, and zygomal fractures. But feel free to ask me questions about anything else. So soft tissue injuries and lacerations, they're very common sports injuries. This patient actually is the grandmother of one of my staff members, and she was at her son's hockey game, and the hockey puck got through, like, I guess one of the nets or guards, and she was like in the audience and hit her right there, and she had a frontal sinus fracture too. So I had to take her to the OR to repair that. So it's not just the athletes, I guess, that get injured or at risk. So like I said, I'm going to discuss all of these different areas that are common. When we see patients with these lacerations, the thing that we want to focus on is actually restoring function first. Obviously, people call plastic surgeon, they want to look good. So obviously, we are concerned about that, but really primarily what we're concerned about is restoring function. And the fundamental of repairs, when you look at something, you want to irrigate, wash it out, make sure it's clean. But for us, you want to debride away tissue very conservatively. So any kind of tissue that looks like it's possibly viable, I keep. You're not going to sharply debride any tissue that has the chance of surviving. Only things that are grossly necrotic or black will be sharply debrided. So those are the premise of all of the repairs that I'm going to describe. Also, precise ligation. You can see here like all the suture ligations of these arteries that were bleeding and pulsating. You don't want to just generally cauterize things without looking at them. So it's very important. I always wear my loupes when I go to the ER, just to be able to make sure you see all of the anatomy. It's not uncommon to see a facial nerve branch or something like that with very deep lacerations, so it's important to go and be prepared. I always bring my own sutures because the ERs also don't always have the types of sutures that we like to use. Lip lacerations. I'm sure you all see very simple things like this. Just from falling the teeth against a hard surface, you'll get a laceration across the vermilion border. How to treat these. I like using anesthetic nerve blocks along the infraorbital nerve so it doesn't distort the anatomy. But sometimes you also need the hemostatic effect of the lidocaine with epinephrine, so you'll have to inject the area directly, but you have to keep in mind that it will distort your anatomy. So the important thing, this looks very simple, and technically it is a very simple thing to do, but you really have to align the red part of the lip, because even just a millimeter off will catch somebody's eye. So that's the first stitch I put in before I repair the muscle, the mucosa, or the skin, is the vermilion border, because that's the most important stitch. It's just like when I do cleft lip repairs, the vermilion is the most important, and the white roll is the most important part of the repair. So you want to look at the anatomy of the lip, the philtral column, the tubercle. If you see the red portion of your lip, you probably don't pay much attention to it, but you have the red portion has a wet part and a dry part. It's extremely important to actually align those two. So there's a distinct border. Here's the dry vermilion and the wet vermilion. If they're malaligned, maybe not as important with men, but with women that wear lipstick, they wear it, they complain about it because the lipstick won't stay on the moist part of the vermilion. It sounds silly, but it's something that will drive somebody crazy. And then you crazy, because they keep reminding you of it. Another important fundamental is making complex wounds simple. So I'm often called in and say, oh, you know, half the lip is missing. 99.9% of the time, even if it's a dog bite, the lip is there. It just needs to be put together. It's just splayed open, especially in young people. They have very elastic skin. So a laceration or a cut just opens things wide and it looks like tissue is missing. So again, same premise. Be conservative, irrigate, wash it out, make sure it's clean. Debride conservatively, only things that are grossly non-viable, and then align your landmarks. And it's like putting a puzzle together. And just each piece that looks like it's supposed to go in a certain place, you put it there and suture it in place and you'll put it back together. So like this girl here, you know, I was told that part of her lip was missing. It wasn't. She had different lacerations here, and this is her just 4 months post-op. Eyelid lacerations. So we get called for the eyelid, but there's very important structures surrounding the eyelid, right? There's the globe or the eyeball, and if there's any question of injury to the eyeball, corneal abrasion, you want to make sure you get an ophthalmology consult. Or an injury to the lacrimal system, you want to get an oculoplastics consult for that. Eyelid lacerations are actually, and nasal lacerations, they're actually, if you're going to have a laceration anywhere in your face, those are the places to have it. The dermis is the thinnest in the body. So the dermis layer is what forms scar tissue. So it's really thin in the eyelid and the nose, so it forms the nicest scars. If you think about like back, shoulder, chest, very thick dermis in those areas. They don't really form, no matter who's closing that, they don't really form nice scars. So I try to reassure parents that, yes, it's upsetting that your child has a laceration on their face and you'd rather it not be there, but eyelid and nose, those are good places to have it because they heal very nicely. A full thickness laceration like this, you're taking that to the operating room. You're not doing that in the ER. There's no way anybody, even an adult, would be comfortable with that. And then you suture it, the tarsus, and you don't put any sutures on the conjunctiva because that would cause a corneal abrasion. You put sutures externally, you secure it closed, you suture the eyelid closed and allow for healing, and then it just heals beautifully. Scalp lacerations. So we don't get called for this that much, except when they're pretty extensive. There's multiple layers to the scalp. It can bleed quite badly, and the question always comes up whether we're going to staple it or suture it. We're getting called in. I'm not going to staple something. It's just anybody, you know, the ER doctors can do that. I really don't think actually in the end there's a difference in the result, because when we work with neurosurgeons all the time, and neurosurgeons staple the scalp all the time, I don't necessarily think there's an aesthetic difference. But I also think in children, using dissolvable sutures to sew up the scalp, it's better. You don't have to take the staples out. But you do have to counsel parents, especially in a growing child, that in the area of the scar, hair doesn't grow. So there are no hair follicles in scar tissue. So they will have an area of alopecia in the area of the scar, especially in a child that is still growing. And here's an example. You see the area. This is just 6 weeks post-op, well healed, but you'll see that in the area where his lacerations were, he doesn't have any hair growing. Ears. I'm sure you guys see this a lot. Ear hematoma, especially with wrestlers. You'll have a bluish hue to it. You won't see the demarcations of the antihelix of the ear. Very, very important to treat this right away as soon as you see it. And the way to treat it is not to aspirate it with a needle, is to actually make an incision along the scapha here. Heals beautifully. You'll never see it. You need to make the incision, open it up, irrigate it out, and then you put a bolster type, either a suture or, you know, some people use these things like buttons, but we don't use that. But basically you just want to get rid of the space that was created by the hematoma so it doesn't reaccumulate. And you don't want the ear to form abnormal cartilage. That will happen in the nose. And you'll see people that have had horrible trauma to the nose, maybe nasal fractures or maybe not a nasal fracture, but a really bad hematoma. If it's left there, it has growth properties, and you develop all this abnormal cartilage. That's why some people that didn't have a huge bump on their nose all of a sudden develop one after a bad nasal trauma. So these you want to treat right away so that you don't get a cauliflower ear deformity, which are, I mean, almost impossible to fix, that deformed cartilage. I've taken care of a lot of kids like that, and you get an improvement, but the ear never looks the same. Ears are very susceptible to being injured, caught on things, and ripped. So they recoil, which is nice, but they also tend to get caught on things. So they get avulsed. So the way I look at it is I have to look and see what is injured. Is it just skin? Is it skin and cartilage? Is there something missing? And if it's missing, you break up the ear into thirds, superior, middle, and lower third, like the lobule, and then that's how I determine what I do. Using absorbable sutures in the ear, 5-chromic is what I use, heals beautifully. So in this kid, it was through the cartilage. I repair the cartilage and then also repair the outside of the skin. These, see often, I don't know if you guys see from earrings getting pulled out. I rarely see them like this when it freshly happens. I usually see it when it's already healed and the skin is grown and it's like a clefted ear. So I usually repair them in the office, just localize them, recreate this by cutting out that skin that is formed and then suturing it closed front and back. I let it heal. I tell them they can re-pierce their ear right in that area after 3 months. But that certainly is not an emergency. If that happens, let it heal, and it can easily be fixed well in the office. This is what happens, you know, when you let an ear wound or avulsion heal on its own. Again, not the end of the world, but so he's left with this little defect. And I did this advancement. The technique is called anti-abuc, and basically you can't really see, but I made incisions all along here and along here, and then the helix kind of gets rotated together to get rid of that gap. The ear does end up being vertically a little smaller than the opposite side and ends up looking like this. And if you put his 2 ears next to each other, yes, one would be a little smaller than the other. But if you look at me, you can't really see both my ears at the same time. You have to look at one and then the other, which is so it really doesn't make that much of a difference if one is vertically shorter than the other. It's just that it looks like now a nice complete ear. I really tried to take out the gory pictures, so this is actually not bad compared to the ones I took out. But the so
see gory pictures.
I was told to take them out. So in this area of the face, what do I worry about? Facial nerve, parotid duct, and so I want to get an exam before or anybody's injecting any local anesthetic to see if the facial nerve is working. So that's important. So obviously, you know, with child this age, he's under anesthesia for all of this. You want to explore the duct. The Stenson's duct is right inside the mouth. You can put a lacrimal probe through it, and that's what I'm doing here. And then you can see whether the duct is intact. If it's not, you repair it primarily. Same thing with the facial nerve. You see it, you tag the ends, and do a primary repair of the facial nerve branches. It's only important to repair the facial nerve lateral to the canthus. Anything medial, they're too small, and there's a lot of redundancies, so you don't need to. So facial nerve injury lateral to the canthus, then those need to be repaired, and only repaired if it's not contaminated. So if this is a horrible dog bite, contaminated, then you're not repairing it primarily, you're tagging them and then going back. So this is the fun part. So facial fractures. Age distribution is kind of the age group that you guys are dealing with a lot. The cause of facial fractures, 14% about, is from sports, most from MBAs, and then assaults. And I guess it obviously varies where the data is collected from, what area of the country. So initial assessments, oftentimes facial fractures occur in situations of significant injury. So they have to go through, usually trauma surgeons are involved in the evaluation of the patient, not always. So you do airway, breathing, circulation. If it's really usually from car accidents or injuries like that, you have to worry about foreign bodies, teeth getting loose, things getting caught in the airway. You always have to worry about swelling in the face and their breathing. C-spine, 10% of patients with facial fractures will have C-spine injuries, so that has to be ruled out, and they're in a C-collar until that's cleared. Obviously, intracranial injuries have to be ruled out, and then obviously the rest of the body too, other injuries. You want to take a detailed history. My history in patients is obviously very focused. You know, I have to ask questions like even like congenital anomalies that they have. These are very important things when I'm putting their face back together. I don't want to get into something that being born with a congenital defect will affect that. Previous trauma, very important. I can't tell you how many times I'm told that, oh, we have a patient with an orbital fracture. I see them, there's literally there's none of this. There's no swelling, there's no ecchymosis. The CAT scan shows an orbital fracture, but then when you speak to the patient, they had a trauma like 6 months ago, and they had a fracture that wasn't fixed. So it's read as an orbital fracture, but it's actually a 6-month-old orbital fracture, and it's not acute. So it's important to examine the patient, take a history. Have you ever been involved in any trauma? Car accident, been assaulted? It's extremely important, especially with nasal fractures too. It's amazing how many times people have been punched in the face or had previous nasal fractures, and that what you're seeing is not new. It's old. Dentition, how their teeth fit together, and their vision too. If they say their vision's blurry, do you wear glasses, contacts, etc. Lacerations, again, worry about facial nerve, parotid duct, and then lacrimal system. So if your ophthalmology obviously has to be involved, there's going to be something going on here with this lacrimal system, corneal abrasions. On the exam, you can, sometimes they're too swollen to be able to palpate any bony step-offs. Want to ask them if their teeth are fitting together normally. Sometimes people have a class 3 malocclusion, meaning their lower jaw is further out. Is that from the mandible fracture, or was this your bite before? You have to ask that question. What was your bite like? And it's amazing, too, how people really don't think about how their teeth fit together until they're in a situation like that. Asymmetries, any bony movement, Lefort 1 fractures, you have to grab the maxilla and sort of pull down on it, see if it moves. Septal hematoma is very important to look in the nose and see if there's blood collected on either side of the septum. So for imaging, I really find plain x-rays are really not very helpful. They're often, it's nice, it's low radiation, it's quick. They often get them at urgent care centers, but they're really not very helpful. Panorexes maybe are helpful for mandible fractures, but standard of care is a maxillofacial CT. And then for the panfacial fracture, it's very helpful to get the 3D reconstruction. This guy had mandible fracture, zygoma fracture on both sides. His whole maxilla, you can see, is moving. Frontal sinus fracture. He was a mess. So specifically, nasal fractures. You can see her nose is deviated. You have bilateral edema on both sides. Another important question to ask somebody is, when I see patients, often they see in the office with a diagnosis of a nasal fracture, they say they hit their nose or whatever, punched. Did it bleed? No. If it didn't bleed, if you're not gushing blood, you likely don't have a nasal fracture. If you didn't get black and blue around, you likely didn't have a nasal fracture. So you want to look for septal hematomas, step-offs, imaging. They always come to my office with these plain x-rays from the urgent care because it's really not helpful, especially in a growing child. There's sutures between the bones, often misread as a fracture when it's not. So there are a lot of false positives in plain x-rays, especially in kids. Believe me, I don't want to radiate these kids with CAT scans, and I often don't need to. If they have an obvious, like this kid has an obvious nasal fracture on exam, I didn't need to get a CAT scan. Here, you can see there's, you don't need to know how to read a CAT scan to know that there's something wrong here. So CAT scans are the best way to see what's going on with the bony septum and the bony pyramid. Timing of surgery for nasal fractures or repair of nasal fractures. So if I see them immediately in the ER and they're not super swollen, I can reduce them there and put a splint on. But if they're just like a potato, their nose, there's no way I can reasonably, because it's a closed reduction. You're just kind of, feeling and putting the bones together. You're not seeing it under direct vision. So I usually like to wait for the swelling to go down 3 to 4 days, 5 days afterwards to fix it. And it depends on the patient, whether you do it, like block them and do it in the office. Most people want to be asleep. And you could do it in a very controlled setting. 3 weeks, too long. You have to re-break everything. So the latest, usually if it's even 2 weeks after and asleep in the OR, I can manipulate the bones and move them into the right place. But for fractures in general, and you'll see, it's, within 72 hours is the ideal time to fix them. You want them not to be so swollen, but you don't want them to be healed. The face is great because there's a great blood supply to it, but it heals very quickly. That's good after you fixed it. but if you haven't fixed it yet, and patients that are really sick, they're in a bad car accident and they're unstable and I can't fix their fractures, I have to wait 2 to 3 weeks sometimes before I can fix it, and it's a big problem. It's much harder. For nasal fractures, I only put internal splints on if the bones are really unstable and collapse, but normally they just end up with an external nasal splint that I take off a week later. They can shower, they just can't get their face wet, no nose blowing, and then I usually keep them out from sports for 6 weeks, although I'm a little bit of a pushover with some kids. Like, you'll see this girl, a lacrosse player, that she had an orbital fracture, she went back 2 weeks later. So these are all sports injuries. So here, again, here's an orbital floor fracture, very classic. So there's just impact to the eye, and the contents of the orbit get pushed through into the maxillary sinus. And you see here, very common, I'm seeing this all the time now with baseball injuries, is the baseball hits the globe, the impact just pushes everything down. And in 25% of the time, there's actually injury to the globe itself. So they have the swelling, they have infraorbital nerve paresthesia, so they're constantly like, my cheek is numb, my teeth are numb, like they don't understand why that's the case. The infraorbital nerve runs in the floor of the orbit and exits the cheek. It provides sensation to your lateral nasal wall, your tip, your lip, and the teeth are right here. And it'll stay numb after you fix it for some time. The last sensation to get back is the lip and the teeth. It's very frustrating. It may not completely come back, but the nerve isn't severed in these injuries, but it's irritated, and when nerves are irritated, they go to sleep. But that explains why their fracture's here, but they're numb down here. Oh, also important is the subconjunctival hemorrhage, the bleeding in the sclera. If you don't have that, you probably don't have an orbital fracture. When bones break, they bleed. And so it really tells you, people don't really examine patients anymore. I feel like they just rely on x-rays or things, but if you actually look at the patient and if they don't have that subconjunctival hemorrhage, I'm not as worried about an orbital fracture.
Just going back to that, so for a symptom of an athlete that we're not sure has an orbital fracture, if they say they are feeling numbness in that area, is that number one of the signs that they do if you can't see it?
It's if they have everything else. If they don't have they will have significant swelling and bruising from an orbital fracture. You can, from blunt trauma to that area, and even if they have a hematoma in the soft tissue, that can cause numbness to the infraorbital nerve. The nerve, again, anything that irritates the nerve will make it go to sleep.
Okay. So it could still be numb, not be fractured.
Correct, yeah. But I've never seen a fracture without numbness, if that makes sense. So here's the nerve, and this is how it runs: floor of the orbit, exits through the foramen, and then provides sensation to this exact area right here. And down here, and the teeth. This is the subconjunctival hemorrhage that they'll have. Okay, this is like the best picture. So this is an ATV accident. This is a late diagnosis meaning late, 24 hours after. And you'll see his CAT scan that happened at this hospital. Orbital fracture, but not very impressive on the CAT scan. And this, he wasn't very swollen. But when he was finally evaluated, he couldn't. Obviously, this is the eye that's the problem. He asked him to look up. This is not going anywhere. So his inferior rectus muscle is caught in the fracture site. So entrapment is a surgical emergency. Why is it a surgical emergency? It's because if it's trapped, the blood supply to the muscle can be just compressed, and the muscle can become ischemic, and then doesn't work anymore. So again, you have to worry about the globe ruptures, hyphemas, retinal detachment, all of those things. Call ophthalmology. What is hyphema? It's blood in the anterior chamber. You'll see their vision is worse when they're laying down, and it clears when they sit up. And that can cause increased intraocular pressure. I do need ophthalmology to clear patients that are super swollen. I can't repair the orbital fracture and put a titanium plate in there when they have increased pressure in their eye. I have to wait for that to go down. I always put them on steroids to help that decrease. So medial wall fractures. So we always talk about floor or blowout fractures. So this is a problem too. See the medial wall here? It should be here. This is all blown out. That causes a similar problem of increasing the volume of where the the eyeball sits. So I always explain to patients, your eyeball is a finite size, so is the room your eyeball sits in. And that room has a roof, a floor, and 2 walls. Once you have a blowout fracture or medial blowout fracture, that room all of a sudden is much bigger. So the eyeball sags and sits in that, so it's a same size, the globe, it's now sitting in a much bigger room. So it will then sag and droop, and you can have a blurry vision as a result. Again, fixing this sort of thing, 3 weeks later, a nightmare. Like 72 hours is my favorite time. I put them on steroids, get the swelling down, I get in there, I reduce the fracture, it's like butter. It's like everything's smooth, everything works. Even after 5-7 days sometimes it just heals, there's scarring, reducing everything just makes it much more complicated. So again, orbital floor fracture, and then the sagittal view is important too. It helps me determine where I need to put the plate, how far back it goes. So these are the 2 views that are important with floor fractures. And again, a bunch of different floor fractures. And then all the contents, and also you want to see blood in the maxillary sinus. This is a true sign of an acute fracture. Like again, you see a patient, no swelling, no ecchymosis, and you're told that they have a orbital fracture based on CAT scan. There should be blood in the maxillary sinus because it's a fresh fracture. We talked about that. And even it doesn't need to be the muscle that drops down, it could just be the intraorbital fat that drops in there that can cause entrapment. These are the trapped, so this is the kid that I just showed you. Like you look at this scan, it's not, like this is it. The bone is barely displaced, so when you compare, so there's no increased intraorbital volume. Same here, barely displaced, not a big deal, but it's this intraorbital tissue that gets caught in here. So basically it broke and then it snapped back and it caught all that tissue in there and it caused that entrapment of fat and muscle. And that's what caused that. And also you have to worry about orbital root fractures, and that's a cranial base fracture. Something else I have to look at when they have these significant traumas. So again, this is a rare condition, but a true emergency. And also, a late finding is vertical dystopia, or just a change in volume of the orbit, and it sinks in, and that's a very late finding. You're not going to see that acutely because they're so swollen. And again, so indications for open reduction incisional fixation are the size of the fracture, the amount of displacement. Again, you're not going to see the dystopia or the enophthalmos because they're so swollen and it masks that. Timing, I really like within 3 days. I immediately put them on steroids to help decrease the swelling acutely so I can repair it at 72 hours. And then it really gets challenging after 10 days because everything heals in the wrong place. How do I get there? My job is to make it look like I wasn't there. And actually this guy I just did a ZMC on the other day, I always say that to them pre-op. I said, my job is to make it look like I wasn't there. And he's like, no, I want you to do the opposite. Because he wanted to sue the person that assaulted him. So he wanted to look horrific. And I was like, no, I don't think I'm going to do that. So I make very small incisions in areas that are, so it gives me access to the fracture, but then it heals nicely. So for orbital floor fractures, I make an incision 5 millimeters below the lash line, right there, and then it gives me access to the floor. So here's the orbital floor right there, my retractor, and this is where I place the plate. And that's my plate of choice. It has a little L on it, a baby L, which is so there's a blue plate, that's the larger plate, and the green plate is the smaller plate, and the right side obviously has a little R. And then it's all the orbital contents are up there, and there's the plate covering the floor defect, and I use titanium screws. Everything I use is MRI compatible, so if they need an MRI scan for any reason, their knee, anything else later on in life, they can get an MRI, and it doesn't set off metal detectors at the airport. These are questions I get asked all the time. If they need dental work done, they don't need to be prophylactically treated with antibiotics either. Another plate. So post-op, here's pre-op, post-op. Same thing. I want to see that the plate is sitting properly in the back. Here's the orbital nerve. You obviously don't want to be anywhere near that. So post-operatively, I get the CAT scan, I keep them on a Medrol dose pack to help with the swelling post-operatively. I put tarsorrhaphy sutures in. What are those? I'll show you. They're sutures that keep the eye kind of shut for a few days because a complication of the surgery is an ectropion or pulling down the lower eyelid. So complications of surgery, very rare. This is hematoma afterwards, emergent, I had to take her right back to the OR. Infections are extremely rare in the craniofacial skeleton, which is good. Ectropion, this is what an ectropion is. You don't want that to happen, very hard thing to fix. So these are the tarsorrhaphy sutures. My patients love me. I actually have that same guy is like walking around with these and like a week later. They come back to my office 3 days after to get them taken out, and he was supposed to come Saturday, he was supposed to come today, he didn't come. So he's walking around with this. So it holds the lower eyelid up, tapes the forehead to help fight those forces of the eyelid pulling down in the acute period of healing. And then I just cut them, and they can shower, wash their face after that. Complications, corneal abrasions, implant dislodgement, I've never had that happen. You screw the titanium plate in place. The numbness can persist forever. Usually doesn't, usually gets better, but a little numbness can persist. You can have lacrimal issues too if the fracture is in your lacrimal ducts. This is one of my, she was a lacrosse player, so this is 2 weeks post-op. So, and she went back to play. Tripod fractures, so zygoma fractures is the last thing we'll talk about. It actually involves 4 fractures, but it's called a tripod for whatever reason. So it involves fractures to the arch, the zygomatical frontal suture, the rim, and the zygomatical maxillary buttress. The floor is usually involved as well. It results from a lateral force. I've never seen a zygoma fracture out fractured. It's always impacted and rotated. Always, always, always. It's either being hit with a pipe or with a bat or a ball or falling directly on the face. So they can usually see a deformity in the face. Obviously sometimes they're very swollen and it's hard to tell and it masks it, but you usually see a significant flattening of the cheek region. They may complain of malocclusion or their teeth not fitting together right, but when you look at their teeth, they fit together well. It's just the sensation that they don't because they have that same numbness, that infraorbital nerve numbness. And again, they have the subconjunctival hemorrhage because they always have a lateral wall fracture. See a picture, the malar flattening. And here, this is the one image I go to right away, is the lateral, I look at the lateral wall of the orbit. This is a zygoma fracture by definition. So that's the only image I need to see, and I know immediately that that's a displaced zygoma fracture. Here's the arch fracture. You don't always have to have a displaced arch to have a ZMC fracture. And here's the buttress. So I have to look and see all the views to really know the extent of the fracture and the displacement. So non-displaced zygoma fractures are kind of rare, but if you see them and they're non-displaced, you can keep them on a soft diet and it's a non-operative management. I think that's the rare situation. If it's displaced, you do an open reduction internal fixation through 3 incisions. If it's just an arch, you'll do something called the Gillies approach, which I'll show you. It's clear liquids for 3 days because they have an intraoral incision, then a soft diet for 4 to 6 weeks. So the first thing you want to do is expose all of the fracture sites. So upper eyelid, lower eyelid incision, in the mouth. You can expose all the fractures through that. So here's the eyebrow. So that's the zygomatical frontal suture. That's the plate there. The plates are 0.5 millimeters thick. So think of how big a millimeter is. They're tiny, tiny, tiny. Like orthopedic surgeons laugh at my stuff. It's so tiny. And the screws are 4 millimeters. And this is the orbital rim, and this is the zygomatical maxillary buttress. And that plate is 0.8 millimeters thick. So you reduce them, and then you fixate them. There's a expression in what we do called, so you know, it's called ORIF, is open reduction internal fixation, but an OIF is an open internal fixation. So you see, like, they open the fracture and they fixate it, but they fixate it in the wrong place. So you want to make sure that the fractures are reduced. You can't just look at one of the fracture sites and think you're reduced. You have to look at all 3 because the segment always rotates. So you can reduce the ZF suture and then you look in all the other areas and everything's off. So So it usually takes multiple manipulations to make sure everything is where it needs to be. Again, here's a good schematic of where all the plates are. Plus minus floor fracture, they don't always have a displaced floor fracture. If they do, you have to put a floor plate there too. Here again, plates, this young kid, it's a sports injury. And all of the plates. This is, it's hard to tell, this is the zygomatic arch, this is a coronal incision, so his scalp is peeled forward. And you only have to use this and plate the arch if it's comminuted. And it's really hard to sell, honestly, to someone to do a bicoronal incision for an arch fracture. No one really wants you to do that. Usually you can do a closed reduction, which is this. So here's the schematic. It's an instrument, which I'll show you. I make an incision right here. Put the instrument, so you don't, nothing's open. Say they just have an isolated arch. You put the instrument down into a certain plane right above the temporalis muscle. It goes under the arch, so it avoids the frontal branch, and then you just pop out. So this is, I did the other, like a few weeks ago. So you see the depression here. You get an isolated arch fracture. This is the Gillies elevator. You stick it in the right plane, under the arch, pop it out. This is his pre-op, that's his post-op. Pretty satisfying. But that you have to do, like, I booked him the next day. Like, you have to do that quickly. Those things heal, like, very fast. You can't do this a week later. And then you never see anything. He has nothing on his face. It's just that incision in his hairline. Complications from, this is a kid, huge. This kid is, like, enormous. He was playing flag football and got kneed in the face. It was one of the worst ZMCs I've ever seen. Like, everything was in a million pieces. He said he felt his whole face just like, he heard it and he just felt it. They can complain afterwards of malocclusion. Again, usually it's just, there's nothing wrong with their maxilla is immobile, neither is their mandible, so it's usually just a subjective finding after just being numb. They can have asymmetry if you don't reduce things perfectly. This was a father who was at his daughter's softball game and he got hit in the face with a softball. So that's him. Here's his arch fracture, plated him in all those areas. So goals are to make it look like I wasn't there. So this is him 1 month post-op. He has perfect symmetry to his face. He doesn't have that dent in his face anymore. And you can't really see his incisions. So it's 1 month, just 1 month post-op. Looks great. And this is that kid. Yeah, here's that kid that was kneed in the face. And this is just 3 weeks post-op, so he still has fresh incisions, but he has symmetry, and here are his plates. This was just a mess, but he was tough. But again, the goal is to make it look like I wasn't there. That's a much cuter picture to look at. That's it.